So my topic of discussion is transition from phacoemulsification to LRCS. So as an introduction, femtosecond laser cataract surgery uses a high precision laser to perform the key steps in cataract, which was normally requiring a blade. So it has greater level of repeatability to create a tissue plane than the manual techniques. So the femtosecond laser system uses neodymium glass and it focuses light at a spot size of 3 microns. It was first FDA approved for cataract surgeries in 2010. So the main mechanism is photodisruption. That is, the laser is absorbed by the tissues and results in a plasma formation. There is a cavitation bubble that is created and this dissects the tissues. So this is the formation of plasma and the cavitation bubble. This is how the tissue is dissected and this is an animation of that. So the key features include the bladeless incisions, which has increased safety and predictability and reduces tissue trauma and swelling. The capsulotomy is more precise with a better improved outcome, especially for centration sensitive IOLs like the torics and the multifocals. The cataract fragmentation, it breaks into softer, smaller units, and so it is easier for the surgeon to take it out with less trauma to the endothelium. So statistically, there is 43% reduction in the phaco energy and 51% reduction in the phaco time. So there's a faster visual recovery and customization is also possible where the surgeon can pre-program the laser to customize the according to the patient's anatomy and astigmatism. Pre-operatively, we need to do a special attention to corneal opacities because the lasers may not penetrate. There's a dense arcus analysis. The pupil size, because we are setting it at almost 4.5 to 5 mm in the machine, so very small pupils are difficult. Very bad zonular dehiscence where there is dislocated lens, laser surgeries may be difficult. We should note the grade and type of cataract because according to that we have to titrate the energy. And the patient should be counseled that the procedure may take place in 2 different rooms. Topical is always preferred because we need the patient to fix at the light. The peripheral blocks may cause chemosis and that may cause suction loss and docking problems. Basically, 2 imaging systems are there, the 3D spectral domain OCT and the 3D ray tracing confocal. These are the commonly used instruments with basically 3 systems, the patient interface, the laser delivery system and the imaging system. The patient interface is a sterile single-use unit which helps in maintaining the position and the mechanical stability of the eye. It acts as a coupling device to facilitate laser delivery and it permits acquisition of the OCT images. Mainly there are 2 types, the applanating type and the non-applanating type. The non-applanating types has a liquid-filled suction and it causes less decrease in the intraocular pressure. These are the commonly used PIs. The main steps include docking, the planning, the capsulotomy, lens fragmentation, the main incision, the side port incisions, and corneal relaxing incisions if required according to the astigmatism. So, first step, the docking. The patient interferes, approaches the eye in real-time OCT overlay is shown. Centration is confirmed and the suction is activated. The IOP may raise to 10 to 20 mm of HG. The next step is capsulorhexis. This is done first and only then lens fragmentation and the corneal incision is done. This is because the gas bubbles that are created during lens fragmentation can distort the plane of the rhexis and cause an incomplete rhexis and also it to avoid increase in the intralenticular pressure by the gas bubbles during nucleus fragmentation. So this is a standard rhexis that is happening on the right side, while during laser surgery, the laser will do the capsulorhexis for us. The next step is the lens fragmentation. This can be customized according to the surgeon's preference, which pattern of lens fragmentation is required. Usually, we keep a safe zone of offset anteriorly and posteriorly. that is around 500 microns anteriorly and posterior offset of 700 to 800 microns. Next comes the incisions. The positions of the incisions can be calibrated according to the surgeon's wish, and usually the length is less than 1750 microns. The arcuate incisions can also be made according to the astigmatism. This is set at a depth of 80%, and the incisions are usually watertight and safe. So this is a conventional phaco incision that is happening on the right side, a triplanar incision with the keratome. While in the laser surgery, the laser does the incisions for us. Now we come to the manual part of the surgery. The usual laser time taken is 30 seconds to 3 minutes. The patient interface is removed and the patient is shifted to the operating room. The corneal incision by laser has to be dissected open with a spatula. The eye is filled with an OVD. We should look for any incomplete capsulorhexis. A gentle hydrodissection needs to be done after tapping on the lens to release the gas bubble. Otherwise, the formed gas will go posteriorly and cause a deficit in the PC. The grooves made by the laser in the nucleus is separated by a chopper and a phacoemulsification is completed. The cortex is aspirated. The general contraindications are a very small palpable aperture because the PI has a diameter of 11.5 to 15.5, and so very small apertures the PI might not fit well. The neck and back problem people, where optimal docking, imaging and laser delivery will need the patient to lie flat. So if there are neck problems, this might not happen. Dystagmus and attention deficit disorders, patient might not look at the light. Glaucoma, the laser causes a suction of 10 to 20 mm of Hg. Corneal opacities, which will hinder the imaging also and laser delivery also. Very subluxated and dislocated lens, the nucleus management may not be possible, but the corneal incision part alone can be done. Hypermature cataract, the liquefied lens material hinders the laser penetration. Very small pupils also cannot be done. So the things to consider is the cost, because the higher cost in conventional cataract surgery is due to the technology, and the operating room logistics, we need 2 operating rooms. The learning curve is a bit high for the surgeon, and there is an increased patient expectation. Unique complication are machine related. Any error in the software can cause loss of suction. We might need to stop or reattempt and switch over to a conventional phaco. If there is a loss of suction, improper docking, excessive high movement, again loss of suction happens. Subconjunctival hemorrhage can occur, pupillary constriction can occur, incomplete capsulorhexis might cause a capsular tear, and the capsular block syndrome causing a rupture of the PC. Advantages are in the incision, greater reproducibility, capsulotomy for better IOL centration, reduced ultrasound energy and effective phaco time. Surgery in the eyes with zonular weakness also can be done because there is less stress during the rhexis and chop. The posterior capsulorhexis alone can be done, and it causes less macular edema. Just finished with a fast video of an actual patient being operated with a LRCS. So this is when the suction happens, a air bubble is formed, and we have got a proper good docking. The real-time OCT is starting. We can customize the incision positions. This is a primary incision and the side port incision. Now here we can customize the depth of the capsulorhexis. This is the size and customization of the main incision. And this is where the lens fragmentation we can do, and the actual laser emission is happening. We can see the cavitation bubbles and the gas formation. The lens fragmentation is happening. And once the incisions are done, we can release the suction and move the patient to the main theatre. Thank you.